Hello, I am Allison Payne. I'm an associate professor in the Department of Radiology and Imaging Sciences at the University of Utah. And today I just want to describe to you some of our experiences we've had with breast MR-guided focused ultrasound. First, I want to just go through some of the benefits of doing focused ultrasound for breast under MR guidance. MRI is the most sensitive of the imaging modalities for breast cancer. And so tumor visualization and targeting accuracy can be quite superior with MRI guidance. An additional benefit is you can have MR temperature imaging for increased safety and efficacy. In addition, multiparametric MRI is becoming increasingly researched and important in tumor characterization, even in breast, and this can be potentially quite important for non-invasive cancer therapy. Now, of course, challenges include it's a challenging imaging environment. The breast can be quite heterogeneous. The presence of fat can be problematic. And of course, use of an MRI is a required resource. It can have a potentially increased cost, and it could also limit treatment sites and how the therapy is deployed. Our breast MR-guided focused ultrasound system is shown here on the left. It is installed on a 1.5 Tesla Siemens scanner that's a wide bore, a 70 centimeter bore. We do have versions compatible with the smaller 60 centimeter bore, as well as 3 Tesla systems. The system's designed to sit on the MR table. It's a modular table support design. It's contoured for comfort and breast tissue access. It also has the treatment cylinder underneath the table. This is where the ultrasound transducer, the imaging receive coil, as well as positioning coils are located, and it has 5 degrees of freedom to allow for good mechanical targeting of the tumor. Now, we have evaluated this system on 10 patients. Unfortunately, COVID has paused our clinical trial. But for these 10 patients, the mean treatment time ranged from 73 to 114 minutes. And this breakdown for each aspect of the treatment is shown here in this graphic. Now, there was a wide variation for many of these aspects that can be improved in for future treatments. A lot of this was due just to the prototype software and algorithms that we were initially testing in these patients. Regardless, none of these patients were sedated. They all had minimal analgesic support, and we are confident that we can reduce this total table time to 90 minutes or less. And these are for tumors that are 1 to 3 centimeters in size. Now, just to highlight a couple of the MR sequences that we were using, the first is a 3D MR acoustic radiation force imaging sequence. This was a really useful sequence. It allowed for rapid beam location to ensure accurate targeting before sonications were performed. Because it was volumetric, it could be quite easily seen. We could repeat it as often as needed. In this particular homogeneous fatty breast, we repeated it 3 times in one location. As you can see, as the sonication went on, the tissue displacement decreased, indicating an increased tissue stiffness. Of course, we monitor all sonications with MR temperature imaging. This is shown here in this video where 3 planes are indicated. It was a thin slab. That was a 3D segmented gradient echo with an EPI flyback readout. Of course, fat saturation was used. Now, we didn't have any respiration artifact correction, but and you can see that in some oscillations in the temperature. However, the focal spot was readily visible, and we could monitor the treatment for both safety and efficacy this way. And the volumetric thermometry allowed full visualization of where the heating was occurring. So to conclude, MR-guided focused ultrasound breast cancer treatment is possible. It can be done without sedation in a reasonable amount of time. We did not have any problems with patient motion at all. We were able to treat 1 to 3 centimeters tumors. We believe this treatment can be completed in less than 90 minutes. Indeed, some of the patients did require less than 90 minutes in treatment. We're currently working on advanced monitoring and assessment techniques. These are under development to increase both the safety and efficacy of this procedure. And I'd like to conclude by just acknowledging my own lab, as well as my collaborators at the Institut Bergonié, where this clinical trial is being held, as well as image-guided therapy. Thank you.
So my presentation is on the MRI for treatment of breast cancer at the University Medical Center in Utrecht in the Netherlands. And this is a brief list of my main collaborators who are involved in this study. So we are working with a dedicated breast MRI HIFU system. This is a prototype that was developed first by Philips and now by Profound Medical. And the difference with respect to the standard equipment is that this is a circular wide aperture transducer that surrounds the breast. And because of the fact that it surrounds the breast, it significantly reduces the risk of heating the heart and the lungs, because basically the beam pass avoids those structures. Now, what have we done in the past? In the past, this prototype was used for a phase 1 clinical trial that was on 10 patients with an invasive carcinoma of the breast smaller than 1 centimeter. And the idea there was a treat and resect protocol with a partial tumor ablation with the study endpoints, safety, feasibility, precision, accuracy, and it ran until mid-2014. The results were published in 2 papers, and the main conclusion was that this breast MRI system allows for accurate and precision tumor ablation. Precise MR thermometry is possible in the tumor tissue, and no adverse effects during or after the treatment were observed. So it's basically a safe system. Now, what do we go from towards now? The present is a phase 2 clinical trial that is approved since end 2019, but stopped because of COVID 2019. The study design is NS10, so 10 patients, early stage breast cancer, with again a treat and resect protocol, but now with a complete ablation, and then followed by surgery and radiotherapy with the study endpoint. Primary is efficiency and the secondary is safety. Now we hope, of course, to start with this very soon. As soon as we get permission from our hospital, then we can start, because it has all the necessary approvals apart from the COVID 2019. Study design is a treat and resect, so starting with MRI of the breast, then the MRI HIFU ablation within 5 days after that initial MRI system, and then within 7 days there is another MRI of the breast, followed by surgery and adjuvant treatment, and of course blood sampling taken at several stages. Now, the second study that we are planning with that prototype system is a phase 1 combination with hyperthermia and Thermodox. Thermodox is the temperature-sensitive liposome developed by Celsion. And the idea of this is that you have an intravascular doxorubicin release in the tissue that is heated, leading to an improved doxorubicin biodistribution, and as has been shown in several studies, and one of them is shown here on the right. That leads then to this high concentration of doxorubicin in the heated tumor, and doxorubicin concentration in other tissues is comparable to that of standard free doxorubicin treatment. The primary endpoint is safety and tolerability of this combination of hyperthermia and Thermodox, and it's the standard adriamycin cyclophosphamide is replaced by Thermodox in combination with local HIFU hyperthermia in stage 4 patient. So you can see the scheme here. So cyclophosphamide is staying the same, and the adriamycin, which is the same as doxorubicin, is then replaced by the Thermodox infusion and hyperthermia in the way that you can see depicted here. Again, followed by surgery and radiotherapy at the end. In the future, so this brings me to my last slide, the role of MRI for breast cancer. I've shown you now 2 examples in the stage 1-2 for the ablation and the stage 4 for the MRI for hyperthermia in combination with Thermodox. These 4 stages, we think that MRI has a big role to play, as well in the ductal carcinoma in situ, where it has not been applied yet. We think also there is a future, and with that I thank you for your attention.
Good morning, everyone. My name is Dr. David Brennan. I am the Chief of the Breast and Melanoma Surgical Services at UVA, and this morning I'm going to give a brief update on the use of focused ultrasound ablation for the treatment of tumors of the breast at the University of Virginia. I have the following disclosure to make. At UVA, we are incredibly lucky to have two clinical focused ultrasound devices, the MRI-guided InsightTech Exablade and the ultrasound-guided Thyrakion EchoPulse. Our initial experience at the FDA made it very clear that we were going to have to proceed in a stepwise fashion, first by treating benign tumors of the breast, then moving to treating patients with advanced stage or stage 4 breast cancer, and then finally treating patients with early stage disease. We've used the EchoPulse device exclusively in our studies. Like I said, we were going to start off by treating benign tumors of the breast, and we did that by treating women who had fibroadenomas. These are typically palpable lesions in the breast. In other words, you could feel a mass in the breast. We treated 20 patients in that first trial with the goal of reducing the size of the tumor as measured on ultrasound and also making any symptoms from that tumor go away. In other words, after completion of the focused ultrasound ablation, we wanted the patient to no longer be able to feel the mass in her breast. So here's a slide showing a patient in that first study. Here we're coming up with a treatment plan. Here's the ultrasound image of the fibroadenoma. Here's that treatment plan. Again, here's the ultrasound image of the fibroadenoma and a sonication pulse and the resulting hyperechoic mark. So this is typically what we saw. These are images from our first patient. On the left, you have the pre-treatment ultrasound image with the volume for the fibroadenoma being 1.53 cubic centimeters. 3 months later, after treatment, the volume was down to 0.47 cubic centimeters. That's a 69% reduction in volume. And as it turns out, that was typical for the 20 patients that we treated. And as you can see here, there's a mean percent reduction in volume at 12 months for the 20 patients in that trial of 68.9%. Based on the results of that trial, we concluded that ultrasound-guided focused ultrasound ablation is a feasible and effective treatment for breast fibroadenoma. It carried minimal toxicity and was very well tolerated by patients. And then we moved on to a multinational, multi-center trial that we hope to be the pivotal trial that will result in the FDA approval of this treatment for fibroadenomas. We're going to enroll 100 patients. We've enrolled somewhere in the mid-90s of subjects so far, and we hope to complete this trial after COVID quiets down. Okay, so we had some good experience treating benign tumors of the breast. Now it's time to move forward with treating breast cancers at UVA. So I wanted to leverage everything we had going for us at UVA, namely that we have a fantastic multidisciplinary breast cancer program. We have an internationally prominent human immune therapy center headed up by Dr. Craig Slingloff, and we have our clinical focused ultrasound devices. I wanted to leverage all of this, so we decided we were going to move forward by treating breast cancer with a combination of focused ultrasound ablation and immune therapy at our program. Our first study used a combination of focused ultrasound ablation plus pembrolizumab, which is a checkpoint inhibitor type of immune therapy, and our primary objectives were to assess the adverse event profile of the combination of pembrolizumab and focused ultrasound ablation in patients with metastatic or stage 4 breast cancer, and to determine whether the addition of pembrolizumab to focused ultrasound would increase the proportion of CD8-positive tumor-infiltrating lymphocytes or T cells into the primary and peri-ablated zone. This is the schema for that trial, breast 48. In the first arm, or arm A, patients got pembrolizumab after the focused ultrasound ablation, and in arm B, patients got the pembrolizumab prior to focused ultrasound ablation. So like I said, patients to be included in this trial had advanced or stage 4 breast cancer, as well as the other inclusion criteria on this slide. To date, we're almost done with accrual in this study. The patients have been pretty sick with visceral and brain metastasis in most patients. They've had extensive pre-treatment, as you can see. We've also treated patients with multiple different receptor statuses, and the side effects have all been very acceptable. The preliminary results from breast 48 were presented by Dr. Dillon at this meeting on November 10th. I'd encourage everybody to take a look at his presentation. So finally, we had experience treating patients with benign tumors in the breast with focused ultrasound, then patients with late-stage disease, and now it's time to start looking at patients with early-stage breast cancer. and that's going to be breast 54. This is the schema from the trial that we're currently developing. There's 3 arms. In arm A, patients are going to get gemcitabine followed by standard treatment. In arm B, they're going to get focused ultrasound followed by standard treatment. And in arm C, they're going to get a combination of the two. So in summary, we've really taken a staged approach to using focused ultrasound ablation to treat tumors of the breast UVA, starting with benign tumors, moving to advanced stage breast cancer, and hopefully soon to early stage breast cancer. Finally, I'd like to thank the following organizations and individuals without whom we couldn't make this happen. Thank you for your attention.
Hi, and thank you for joining us. We are now fortunate to have the experts that provided the prior presentations now joining us, along with Dr. Mann and Bratt, to understand the potential role of FUS in the treatment of breast cancer. I'm happy to report that there are currently 9 clinical trials with focused ultrasound in breast cancer using 5 mechanisms of action, including thermal ablation, ablation and drug delivery, mild hyperthermia and targeted drug delivery, radiation sensitization, and blood-brain barrier opening for drug delivery. I was hoping to start this conversation about ablation. Studies to date have reported varying ablation rates, and the question is, how do we get maximum local control of an index breast lesion with focused ultrasound? And how do we even assess that we've gotten local control with the focused ultrasound? So perhaps Dr. Moonen, you'd like to start this discussion about ablations?
Thanks. Yes, of course. One of the problems is, as you mentioned, is that how to assess what we really did. Of course, we want to have as much as possible of the tumor, and we want to really describe that with either MRI or with ultrasound. And so far, the methods that we use to do an contrast-enhanced, either MRI or contrast-enhanced ultrasound, well, that doesn't work that well in breast cancer, probably because of the fairly low perfusion, and that's one of the things that how can we improve that? Can we look at T1, T2 if you're doing MR, elastography, so other types of measurements that can better describe what we did and that we can actually already do after the treatment. So that's one thing I think that we have to improve on.
Mm-hmm. And Dr. Bratt, do you have anything to add?
I would use MR for the assessment of the treatment success and probably wait a few days. And I think that you need to combine all the sequences you have to do right assessments. So use your DWI and your ADC. If it increases, it's better. Use not only if it enhances, but also the kinetics. If it enhanced very quickly with a quick washout before treatment, and now it's slowing down, those are signs that you did something. So those are positive signs. So I think you need to combine all those parameters to see if there is a good response, and that we should learn from histology or pathology and MR and its correlation before we know exactly what to see and what to do with the outcome.
Interesting. So imaging to make sure that we ablate the tissue is super important. And Dr. Payne, with your machine, can you tell us a little bit about how you think we can get improved ablation rates and achieve that local control?
Yeah, as Dr. Moonen mentioned, whether you're under MR guidance, as in my case, or ultrasound guidance, there's a lot of options of quantitative metrics you can use to monitor the treatment and assess it. And I think some of the things we're working right now perhaps aren't the most optimal. And so by improving the technology and by improving the way we're assessing what's going on during the treatment and after the treatment, I think we'll have a much better chance of just being confident that we've actually treated the tissue we need to treat. Because this is a non-invasive technique, and we're asking patients not to go with the current standard, which is to remove the tumor. They need some kind of assurance that what we've treated is truly no longer viable tumor. And so I think we're all just trying to move towards that.
Yeah. And Dr. Brennan, I know you have some strong feelings about where focused ultrasound can kind of play a role in this ablation and local control. And from the clinician's perspective, perhaps you can add to this discussion.
Yeah, I mean, certainly from the clinician's perspective, the endpoint is control of disease. So that you want to cure this patient of her breast cancer. So, and one can argue whether we actually need to treat 100% of the tumor in order to do that. It's certainly nice to think that that's what we're doing currently with surgery when we do a lumpectomy, but that probably isn't entirely true. So perhaps that is a false bar that we're setting for ourselves here. Ultimately, and this is probably not that far off, if we could get a good biomarker of disease, that's going to be very helpful. And there's also, while it's minimally invasive, we can always rebiopsy if there are areas that look to be incompletely ablated. So there are approaches that we can use in the clinical setting that would be effective to gauge the success of our treatment.
Yeah. We just actually had a question that came in, and it says, clinical staying power is often related to patient throughput. What are the barriers to reducing the treatment time for MR-guided focused ultrasound breast treatments? And is there a lower bound of treatment time due to the physical device? So perhaps we'll start with the MR machines. Perhaps you can comment on that. Dr.
Yeah, I'll go ahead. Yeah, in the clinical trial we've been running for small tumors around the size of a centimeter or a centimeter and a half, our goal has been 90 minutes of total treatment time. The patients seem to tolerate that quite well without sedation. And I think that's a reasonable goal for both patient throughput. That's not too much longer than just a standard MR exam. I think any longer than that might be difficult, but if we go to treating larger tumors, then I think we'll have to do that. And of course, there's also, if you have to do a longer treatment time to ensure you're getting the treatment done, then that's something we have to consider.
So that's a very interesting question. People talk about how long focused ultrasound ablation takes, but it really depends on how you frame that, right? So tomorrow, I'm a breast cancer surgeon, at least for the audience might not realize that. I'm going to operate on 5 women with breast cancer. Okay, I'm going to start my day at 7:30 in the morning, and if everything goes great, I'll be done around 4:30 or 5 o'clock. So do the math there. How long did it take me to treat each one of those 5 women? So that's from the treatment point of view. From the patient's point of view, even if you look at it that way, right, the patient had to show up, get checked into a preoperative area, have an IV placed, hang around, wait for the operating room to become available, go to the operating room, do the operation, then go to a postoperative recovery area, then go to stage B recovery, then go home. So the treatment really, even when we do surgery, my operative time might be 25, 30 minutes. But the actual entire treatment time is hours. So 90 minutes, if a patient just shows up, lays on a table, gets off that table, does a brief recovery, and goes home, that's pretty good.
That's a really, really good point that you brought up, Dr. Brennan, because sometimes we don't consider all of that in addition to it. In addition to the fact that in your practice, and I'm sure the women that enter these studies, there's a big difference between having a lumpectomy and having a completely non-invasive procedure from a cosmetic standpoint. So what are some of the issues that all of you have faced in hearing from patients about why they would like the focused ultrasound? Can we promise them that there won't be any breast deformity after the focused ultrasound procedure? Or perhaps if we get some fat necrosis, they will have a small a lump in there, be it benign. So perhaps, Dr. Bratt, you can start this discussion on women's preference and what we can promise them and what we can't from a cosmetic perspective.
Wow, that's a good question. I never make too much promises. Well, I'm not the treating physician. I'm not a surgeon like Dr. Brennan is. So I normally biopsy the tumor and do all the radiology stuff. And in our current trial, we did in our finished trial, we only did partial ablation and they had to undergo breast conserving surgery after. So they still had the lump and the lumpectomy, and most of the tumors weren't palpable, like most of the tumors are not before you treat them in our country, at least. So I don't know. In the first study, we didn't have palpable lumps after a week that weren't palpable the week before. But as the time to surgery was only 1 week, I don't know if the fat necrosis, which probably will take a little longer, was a real issue. So my answer is I actually do not know. I only know that the patients that do contact us for non-invasive treatment are very inclined to have a nice cosmetic result. That's their most important focus to search for non-invasive treatment. But I don't know, maybe one of the others has more experience.
Anybody else?
So I can only speak to, treating fibroadenomas without excision. And all of our breast cancer studies have been late stage disease. So to date, we're working on our early stage study now. But certainly in the fibroadenoma patients, the cosmesis is excellent. I mean, you can't tell that they've been treated in the long run. Early on, certainly the first couple of days after treatment, there's quite a bit of edema and a mass in the breast. But that slowly resolves as the effects of the ablation itself go away. Most often, almost always, our patients started the treatment with a palpable mass in the breast, and then over time, at least in our first study, I think only 2 out of 20 still had a palpable mass, and we didn't see any fat necrosis, but we confined the treatment entirely to within the fibroadenoma. And to me, that's going to be probably one of the key things until we figure out how to potentially avoid fat necrosis after treating normal breast tissue. Because if we treat normal breast tissue, I think we will see fat necrosis, which ends up being, again, for the audience, a palpable mass that can be disturbing to the patient and certainly the treating physicians. So.
Yeah. Well, it seems as though we're all working towards getting improved local ablations, but now what's really interesting and what's been highlighted in this conference is this combinatorial therapy. And perhaps Dr. Padilla, you can start us off by having this conversation of the exciting new combination therapies that you're working with.
Yes, we learned a lot, especially yesterday during the immunotherapy sessions about novel exciting combination with HIFU and immunotherapy. I mean, we learned from UVA that the thermal ablation with gemcitabine can confer tumor growth control and can enhance the response to anti-PD-1. So I think that should lead to a novel clinical trial. We learned about the combination of microbubble destruction with first to lead an anti-vascular disruption therapy when combined with the treatment of care, paclitaxel, and anti-PD-L1 conferred complete regression in almost all the animals treated. So that's very remarkable, and that should also lead to novel clinical trials. We reported that for example, the timing of the combination of immunotherapy and first can play a role in the response. And I think we are very excited to hear the final results of the current trial at UVA to see if starting, for example, with anti-PD-1 and then HIFU or HIFU and then anti-PD-1 can lead to a different response. The last 2 points I would make. So first, I would like to point the audience to the guideline that we published on the FUS Foundation website, the recommendations on how to monitor the immune response in a clinical trial with FUS. And I think even in the case of pure HIFU with Dr. Payne or Dr. Moonen systems, that would be truly informative to develop rationales for future combination with immunotherapy to have all this set of informations. And the last point is that we heard a lot about also novel treatment modality, histotripsy, and its potential for immunosensitization or vaccination. With the Sonalive system that Dr. Moonen is using, you can perform boiling histotripsy lesion. I mean, it's been published. So I don't know if there are clinical trials planned with that, and probably Creed can comment. But I think that that's also a very exciting new avenue.
Yeah. Creed, do you want to talk about your new exciting combination?
Yes, this is based on the preclinical work by Avinash Iranki, who presented yesterday on the combination with histotripsy, but that was on neuroblastoma. We are not planning. We don't have any plans to do this on breast cancer, but we are planning a phase 1 clinical trial on other cancers with this combination of histotripsy with the Sonalive system and checkpoint inhibition, but that's not on breast cancer for the moment.
Mm-hmm. So I have a question for everybody. Do you think shorter FUS treatment sessions that ablate less than 100% of the tumor are more realistic? Furthermore, do you think shorter, less ablative treatments will combine the best parts of what we know about immunology and complete surgical resection? Dr. Brennan, would you like to start?
Sure, I can take a stab at that. I'd say yes. That's the short answer, right? So the treatment of breast cancer is multidisciplinary, and it's moved a long time ago from a surgical treatment. At most cancer centers, we really are leveraging everything we can, and as we use multidisciplinary treatment, systemic therapy from medical oncologists, radiation from radiation oncologists, immune therapy, and surgery, we're actually able to dial back each one of those treatments in terms of the radicality of them. Mm-hmm. If you just think about the history of the treatment of breast cancer, right? We went from radical mastectomy to modified radical mastectomy to lumpectomy and axillary dissection to lumpectomy and sentinel lymph node biopsy, and now often lumpectomy alone for women over the age of 70 with smaller ER-positive tumors. That didn't occur in a vacuum. That occurred as we've advanced systemic therapy from no chemotherapy to really horrible toxic chemotherapies to chemotherapies that are less toxic to endocrine therapy, which is much less toxic, and then radiation advances from really horrible toxic radiation therapies to now we do partial breast radiation and intraoperative radiation with a single treatment. So all by leveraging all three of these approaches, we'll be able to dial back what we're doing. And there's no reason we can't take that to the next step to dial back the invasiveness of the ablative part of the treatment from surgery to ablation. So I think that, yeah, we can do that as long as we bring in all the other technologies to bear on treating these patients. It's not all about getting the cancer, killing all of the cancer in the breast, because that is probably a fallacy. We're not killing all the cancer in the breast with surgery. It kind of feels like we are, but we're really not. And we know that we don't have to. And we routinely leave cancer behind now. In the most obvious way, when we with patients when we do sentinel lymph node biopsies, it's routine now if a patient has 2 or fewer positive sentinel nodes to leave the rest of the lymph nodes alone. And we know in that setting that we're leaving cancer behind in the axilla at least almost a third of the time, 28% of the time. And those patients do just as well as those when we do an axillary dissection. We know that we're leaving cancer behind during surgery, because if we weren't, we wouldn't need to do radiation therapy. So I think that if we can leverage more than 3 approaches now, potentially, we'll be able to minimize each one of them to give patients that same excellent outcome with a less invasive treatment and less toxic treatment.
Right. So as you said, the field was going towards getting less invasive and less toxic from all of these combinatorial therapies. So focused ultrasound could really play a role in each one of those, right? Less surgery invasiveness, less chemotherapy needed on a systemic level, less radiation perhaps necessary. So, we're just kind of one of those things that will probably help that that goal. So thank you for putting that in perspective. We have 1 minute left, so maybe we can just get your final opinions in from the panelists here about what's your best hope. What do you hope to see in the near future with breast cancer treatments? Dr. Payne?
I hope we can just develop really robust technology so that we can add to this arsenal that Dr. Brennan described. That, a breast cancer survivor once told me that, at the time I was just worried about treating my breast cancer. I didn't realize I was going to have to live with these effects the rest of my life. So really providing an option with better cosmetic results, I think is really beneficial.
Great. All right. I'm sorry we don't have any more time. It seems like we needed more time for this session, but I really appreciate all of your input, and thank you so much to everyone.
Thank you.
Thank you.
Thank you.